Hey, everybody. Welcome to this week's Dentistry Unmasked. I'm Pam Muniz, Chief Editor for Dental Economics Magazine. With me, as always, my sidekick.
Hey guys, David Rice, Chief Editor at Dentistry IQ. How are you, Pam?
I'm doing well. I have to ask you a question.
Okay.
We never really talked about this before. When you had your practice, did you see kids?
Very, very well behaved kids, but I was traumatized as a resident. How about you?
Kind of the same. So I love having kids have to come in through their families. So if a child comes in, they can come to hygiene, and I feel really strongly that we have a really great preventive program in my practice. But for those that need restorative, out you go. You go to pedo. I don't want to be your first go.
I think that makes a lot of sense. And we have somebody here today who's going to shed a lot of light on maybe why.
Oh my gosh, you guys, we've got the best guest. You ready for
Yay.
this? Dr. Anand Patel. He is a pediatric psychiatrist. So if we don't understand how to manage kids, or maybe we get challenged by it, or maybe we're still remembering kind of old school techniques that we learned in our pediatric rotation in dental school, he is going to debunk all of these things and help us have better relationships with our pediatric patients should you treat them in your practice. Anand, welcome.
Thank you for having me. It's a pleasure to be here.
You're already my hero because you literally spend your day in and day out, working with younger patients. Honestly, that's probably part of the reason I'm a prosthodontist, is that I don't have to do that. So kudos to you. Now, I want to start with talking about maybe some things that we should recognize in our practice, because I think sometimes parents will come in and they'll be like, oh, little Joey's scared, or he doesn't like the dentist, and maybe he's never even had a dental experience. And so, or they're like, oh, I don't like the dentist, and I basically taught my kid not to like the dentist. What can we do to identify these as, maybe it is situational and behavioral, but maybe it's something a little bit deeper than that?
Yes, I think in any field, whether you're in psychiatry, whether you're in the dental world, whether you're in business, I think it's extremely important. That first visit is extremely important. Developing rapport can feel like one of the hardest things to do, but I think that the most important thing to realize that all human beings, um, if they're adults, if they're older adults, if they're children, if they're adolescents, if they're young adults, all human beings crave validation. And I want to spend a little bit of time on validation because I feel a lot of times when people hear that word, it gets misconstrued as meaning you have to agree with the other person. That is not what validation is. Validation simply means that that even if you don't agree, that you're having a conversation and you're communicating with the other party and meeting them where they're at, and sending the message that you hear them, that their opinion and where they stand and where they are is valid. And I think that's really, really important. And I think that there is not very good training across the board in teaching validation.
I can imagine, because I've worked in a practice that I think we tried to validate people, and we would just say, I hear you. And I don't think that is adequate. So, how can you, and I know there's no way in our brief time together, clearly already, we're going to have you back, but how would you say we can learn validation, and what are some tips we can take home with us today?
Yes, that's a really good question. So in the field I work in, I when I see a patient for the first time, we're having an initial evaluation. There are large packets that families have to fill out that gives information about, social history, medical history, psychiatric history, um, and triggers and those things. So we good providers will read them, and one of the one of the best things that you can do to develop validation in an initial appointment is kind of bring some of those topics up. For instance, if you see in an initial packet where it's written that there is some sensitivity to noises, for example, loud noises bother you. It creates anxiety, or it creates anger or irritability. And I try to use that information to help me develop rapport with the patient. So I might say something to the effect of I know that fan's making a lot of noise in my office. I'm really, really sorry. Would you like me to turn it off? So it like helps them to understand. One thing to remember as well, I want to kind of go back to this. Adolescents especially are in, and this starts about age 12 to takes you to about 19. They're in, there's an old school psychologist named Eric Erickson. He says that teenagers are in a stage of life called identity versus role confusion. So what that really means is that they're in a stage of identity, trying to figure out who they are, trying to figure out what they believe, trying to figure out if everything that they've been raised with is right or wrong, while developing their own abstract ideas and thoughts. So in this period of time, there's a lot of thought process that we call like black and white thinking, that there's not a lot of grays. So it's either you're right or you're wrong, or you're bad or you're not. They have trouble kind of thinking abstractly, or they think very rigidly. So their default thought process is that adults don't understand. And so if you're giving off the impression, even if it's not intended, that you're doing the opposite of validation, that you're invalidating them, their brain already tells themselves, see, I told you, they're not listening. So the way to combat that is a simple, I'm really, really sorry that you're going through this. I'm really, really sorry that this anxiety is causing so many challenges for you. And just starting with a validation first approach in initial meetings might change your whole rapport with the patient. Because what it does is it kind of signals to their brain that, hold on, wait a minute, maybe they are listening. And after that, more times than not, they're more willing to hear what you have to say after.
I have a
That's
question about this. What age do you start validating young patients? I mean, when I'm hearing you and I'm listening, I'm thinking this sounds like a conversation I would probably say or have with maybe an adolescent, or, somebody who, maybe 10 years old, maybe, and, something like that. Or does it go younger than that? Like, would you have this conversation with a little baby kid?
You can have you can show kids that you're also validating them even if they're really young. So that it might look a little bit different. So it might be like finding out what they're interested in and talking about those things. So younger kids are very, very inclined to kind of show their own rigidity in ways, because their brain's not as developed, to want to do and want to talk about things they are interested in. And so if you're showing that interest to them, they're also more willing to participate in therapy or in a visit. It could be as simple as, oh, I noticed that you like Ninja Turtles. Here's a Ninja Turtle stress ball you can hold while we're doing this activity, or while we're doing this procedure. And I think, again, like that is a form of validation you can show to younger kids. They still get it. They're like, oh my gosh, the brain's still going to say, oh, wait, they're listening. So yes, to answer your question, I think that there are ways to validate younger children.
What about parents? So, we're talking about triggers of kids that we see. I would, and also, parents and the influence they have over the kids based on their, past experience, or maybe they never got out of that whole the world is black and white and not gray in the middle. Like, we see kids in our practices. Well, Pam, I guess we've just admitted that we see like the best kids in our practices, but um, how does how should we deal with parents in this scenario, knowing that their children have triggers and probably they're bringing their own to the table too?
That's a really good question as well. So, we have this saying in child and adolescent psychiatry that that our job sometimes it has more significance in terms of you're not only treating the child, you're treating the whole family. And so those parents also need validation as well. And so I think just letting them know that validating them that it's not easy and that you know that and you see that and you can feel that, I think will also help with overall compliance of treatment, whatever that treatment is. Because if the parent feels validated by you, then they're also more inclined to participate in the treatment, which is sometimes even more important because the kids are relying on the parents to have that compliance in treatment.
So it sounds to me like we need to start assessing this well before the child even comes into the practice. So I know for me, a new patient, we will email them new patient paperwork, but it would almost behoove you to ask for them to send it back well in advance so you can actually review it. Oftentimes, and I'm at fault of this if this is a bad thing, I do it all the time. I review the new patient paperwork with the patient there, and usually the first time I'm looking at their paperwork is right before I walk into the room. And so I would imagine for a pediatric patient, especially one that comes with some sort of anxiety or a special need that we need to address or give special attention to, getting that paperwork maybe a week in advance would be really helpful because I mean, I don't have a Ninja Turtle stress ball right now, but I'd get one, but I
Right.
just need time to do it.
Correct. Absolutely correct. It would be beneficial to and I know, listen, I know it's difficult, like reviewing paperwork amongst all the other, you know, stuff that you have to do and get done in a day. It's challenging, but for me, the way I look at it is if you are able to review those things a little bit in advance, it actually makes your job much easier as time goes along in future follow-ups. I've always found that you might have to take more time in that initial visit developing the rapport, getting all the information, being thorough, etc. But what I find is like when you do that good work up front, then the follow-up visits actually become much more smooth. And I think you actually save time later.
I would buy that. And Pam, I think, this makes me think of you as a specialist and the difference in the level of care that a pediatric dentist may provide versus myself as a GP. And it's really probably got very little to do with the clinical dentistry and everything to do with exactly what we're talking about right now.
I would think so too. And it's interesting. Just yesterday, this happened literally hot off the press. I had a patient sit down with me and she was asking me about an experience that a family member of hers had in a totally different state where the doctor was supposed to place a composite or something on the patient and they put the topical anesthetic on and it dripped down, as we all know, it goes sometimes where it's not supposed to. And the patient felt it in her throat and she got really nervous and she got really scared. And it kind of sent her down a spiral where she really struggled and they would not allow the parent in the room.
Hmm.
And the doctor put his hand over the patient's nose and mouth as a way to calm them down. And when that didn't work, they stormed out of the room and slammed the door. And so
Helpful.
she asked me if that was normal. And I was like, I don't know. I don't see kids, but I can tell you right now, I would never do that. So for many reasons. So Anand, how many bad things did I just say in this story?
In one sentence. It's a great game.
Oh, yeah, definitely. It's it's a slippery slope. Like when we talk about, physical interactions with the patients, like sometimes you have to do it. Sometimes you have to, when you're doing procedures, you're going to, have to, maybe put your hands somewhere to be able to do the procedure. But look, again, I want to, one thing that I want to mention there, we have to remember that again, kids' brains are not fully developed. So certain things are going to be a little bit more challenging and difficult for many of them. Maybe not all of them, but one of those things is like changes, transitions, the unknown, uncertainty, unpredictability. Kids have a lot of trouble with that. I mean, adults do too, but kids are going to do much better when you can set them up with as much predictability as possible. So if you let them know, for example, I might have to put my hand on your shoulder, or I might have to put my hand on your ear and maneuver it a certain way so I can, see in your mouth better, for example. I'm just kind of like given a scenario, but if just by giving them that predictability, whether you do it while you're in procedure or like in advance, like if you're explaining the procedure to them before you do it, that will help significantly. I wonder if the patient would have reacted the same way if they knew that, you know, this is the way the procedure was going to go, and there could be a chance that some of the liquid material goes down your throat and you feel something. If you do, it's not something to worry about. It's not going to harm you in any way, but just let me know if it does because it might feel uncomfortable. Like just kind of like putting those feelers out there for them, again, will make a world of difference in most cases.
You
Yeah,
also
it's fascinating.
mentioned, sorry, we both have so many things. You mentioned before we went on about an intake form. And
Yes.
you were saying that there's some questions, simple questions that we could add to our paperwork to I try to identify some of these issues because I think a lot of us sort of shoot from the hip. We want to give a child a good experience. So obviously we go in and we try to be like extra upbeat, extra happy, more fun. But when things start to go sideways, maybe these are things that we could have prevented in the first place. So, would you share some questions that we could add to an intake form that would help us give this child a better experience and help us prepare better as healthcare providers?
Yes, definitely. I think some of the simple questions that you could put on there, like I mean, I don't know how you would word this, but you could say, on a scale of 1 to 10, with 10 being the highest, one being, so 10 meaning it's affecting my daily functioning a lot. One being it doesn't affect my daily functioning much at all. Um, and then you could put things like changes, transitions, the unknown, uncertainty, unpredictability, and have them just rate those things. So you can kind of see. So anything that's like 5 or above, I take seriously, um, because it tells me that at some level it's uncomfortable. Um, so that would give you a general idea of like um, how much that could affect them. Then you can look at the sensory things. Same thing, scale of 1 to 10, loud noises. And then maybe you can have a box next to it for them to put a few specific noises that bother them a lot. Um, you could put textures. Um, does hot or cold bother you? Because I know in the dental world, you guys use a lot of liquids and they're all different temperatures. So that might be good to know. Um, and and then I think another thing is like when like a question to the effect of like, when you feel anxious, do you usually react with panic, worry, irritability? And I think like that will also help you as a provider, because if you can, if you see certain signs and you're paying attention and you start seeing, okay, like this patient's getting a little ramped up, maybe I need to like back off, because they might get irritable. And that's also for you to know too. It's also helps the provider out to kind of know, you know, how this patient could react if they get too nervous. Does that make sense?
It does. It does. And actually, so speaking of signs, you know, whether it's something maybe we're discovering in the chair in the moment, or Pam, I think to your point, if we take some more time on the front end to learn more about, you know, the child who's going to be in our chair, you know, at what point does it make sense for us to say, hey, I'm a general dentist. Maybe this child is best served in the hands, before we ever jump in and find out the hard way, you know, to be working with a pediatric specialist, so they have the best possible experience, in hopes of, by the time they get to myself as a general dentist or Pam as a prosthodontist, that they're not fearful, that a lot of those anxieties do go away. Like you know, what kind of signs should we be looking for, disorders, things like that, to help us?
So signs of could you repeat that question? Like signs of,
Yeah. So knowing that maybe some of this stuff is some of these things are signs of a child who's well adapted and can
okay.
tolerate treatment, versus a child who maybe has a disorder or some things at a deeper level that we we shouldn't go for it. We should work immediately with a specialist to put them in the best possible place, from a safe space and having a
Yeah.
great experience.
I, I would definitely say that. So there, I'll start with this. One of the first things we learned in my child and adolescent fellowship was, when you look at something like depression in a child or adolescent, it looks way different typically than depression in an adult. Adults present very textbook, or like very typical of what you might think you see in a TV show or read in a book about, you know, being very, very sad, or not engaging in their hobbies, feeling very hopelessness, you know, and maybe having suicidal thoughts. But the hallmark symptom of depression in child and adolescent psychiatry is actually irritability. And that surprises a lot of people.
Yeah.
So this becomes a really important topic in our world, because irritability can be scary to a lot of people, because it can lead to anger and aggression. Um, and it could be misunderstood as uh, other psychiatric disorders, and kids can get misdiagnosed, such as like bipolar disorder, things like that, when in actuality they have depression. So one of the really big things to remember is that if you see irritability, um, this could be a kid that is struggling with depression, and it might be something to pay more attention to. Um, and it could be actually like something to include in those intake forms too, where, you know, you're asking about safety and you're asking about depression. But I also want to connect it to some of these things that we were talking about before. If you develop that rapport, um, you're more likely to get direct communication about that if it's there. Um, we also have to remember, even if, like, just like, you know, kids might not want to talk to their parents. That's why therapy is so important. Um, Sometimes we play the parental figure as therapists too, and they might not want to talk to us. So they might talk to somebody else that they feel more comfortable with in that moment. So again, that really leads to like a discussion of, everybody that's involved in that child's care is an important part of their, well-being.
So sometimes when you treat an adult, and this happens definitely with Pross and David, I know you've seen patients like this, where sometimes a patient gets like fixated on a temp, or we can't get them happy because maybe they've got some semblance of body dysmorphic disorder. And we've all said it to each other as colleagues and sometimes to our team, like, look, man, they don't need a dentist. They need a psychiatrist because this is more than just a line angle on a lateral incisor. Like it's just more than that.
Yeah.
How do patients make their way to you? And how do we, as healthcare providers that see patients on a frequent basis, how do we identify that maybe it's a little more than they just don't like to go to the dentist? Maybe they do need to see a psychiatrist. And how do we have that conversation with the parent?
So I do think that it's really because good thing about the state of Massachusetts, everybody's required to have a primary care physician. So I think that that's super important. Having that discussion, I think very, matter of fact, and saying, look, like I'm concerned about this, I think is valid, and to be able to tell parents directly about that as well, and seeing if they're comfortable for there to be communication with the primary care physician, because the primary care physician can really look into that further, number one. And number two, if they agree that there needs to be a psychiatrist on board or there needs to be psychiatric services, they're the most equipped and more well and inclined to start to set up the referral process for that.
What if the parent says, oh, they're just 15 and they're just a jerk right now?
That's hard. Because that's one of those gray areas where it's not like a mandated reportable situation. So a lot of times what I try to tell myself is, and I really had this struggle in training my my attendings and role models in residency would would always get on to me because they would say, Dr. Patel, you can't fix every situation. And so like I was young, raw, and that's just how I proceeded. So I learned a big lesson right after training in my first position without the help of attendings, is that like now the responsibility is 100% on you. And if you take all these things on, you will get burnt out. And so sometimes, one of my mentors, I remember, is like, sometimes you have to let them go home and be okay with them having to come back. And so I've really taken that advice to heart, and I've tried to implement that in my practice now. And so it's something I'm getting better at. So I try to pass that along to trainees as well, because I can see that same kind of drive in them to want to fix everything. But there are some times that I think you validate them where they are. I keep going back to validation. You validate them where you are, but then you let them know if this is something that you want to talk about later on. Like, we're here, we're here to help you, and we're willing to do whatever we can to have the patient be in the right place for treatment.
I like that. And I think, coming full circle, the validation is so important for the kids in the chair and for the parents who are there too, because everybody's involved in this equation. Pam,
Right.
there's so much more for me to learn about kids.
I know. And honestly, I'm fascinated because
Me
obviously
too.
I don't see a lot of children, but I feel lucky that the ones I see are pretty easy, obviously.
Yes.
But I also think that there's a lot of us out there that see lots of children. And also, maybe, I mean, we all are striving to get better and better. So I feel like being able to identify these things earlier and maybe identifying things that trigger a child. I feel like there's more triggers now than ever. And I feel like we need to really be generous with giving them a good experience, because this is really going to set the stage for the rest of their oral health life and possibly, their relationships with other healthcare providers. So, like I said in the beginning, Anand, we're going to need you back because we're just not done with you.
There's so much more.
Yeah, I'll be happy to be back.
Well, thank you so much. And I'm
Thank
really,
you.
I appreciate you for sharing some of your takes on how we can better treat children and even work with parents, because it's not always easy and it's hard to navigate that sometimes. There's a lot of emotion there. So, David, you want to take us home?
Man, I don't want to, but I feel like, of course, we have to. So, friends, if you're seeing kids right now, take a lot of this to heart. If you're not seeing kids, you're afraid to. Maybe you've got some great tips and tricks. And, until next week, I guess we're going to say, see you for now.
That's right. TTFN. Ta-ta for now.
I love it. Bye, guys. Thanks for listening and watching. Thank you, everyone, for watching or listening to the show this week. And thanks to our guests and sponsors on this episode.
Please check out our social media at Dr. Pamela_Maragliano and at Dental Economics Official.
Or you can check me out at Ignite DDS or at Dr. David Rice.
And go to dentaleconomics.com to receive dental economics. You can choose to receive DE in print or digitally, and you can also get the details of our Principles of Practice Management conference on our website.
If you have topics or guests or anything you'd like to talk about on the show, send us an email to dentistryunmaskedpodcast@gmail.com, and we will do our very best to make it happen. Thanks again, and we'll see you next week.